In this first picture here, you're going to see we're going to be looking at our oropharyngeal airways, OP airways. These come from small infant to large adult. They come in all different sizing. And the purpose of them is they're stuck in the mouth and they come and they help take the tongue off the back of the throat. When a person becomes unconscious and all the muscles in the body relax, the tongue tends to fall over the back of the throat. That is the number one thing that will block an airway in an unconscious adult. So by putting this OP airway in, it holds the tongue off the back of the throat and will help us maintain an airway. So if we need to bag the person or help give them more oxygenation, they're able to accept it. The way we size them is we put the phalange part of the OP airway here at the mouth, and then we measure this curve here, comes right here to the curve of the jaw. Now, it doesn't have to be exactly perfect like this one is, but if it's way too short, it can actually push the tongue down on the back of the throat and actually block the airway, which is the complete opposite of what we're trying to do. And if it's too long, it can actually go into the trachea itself. So that we do try to size them. These are only tolerated by someone who is unconscious. If you are awake, your gag reflex would not allow this to go in. So this is for an unconscious person to help keep the tongue off the back of the throat and support the airway. These are inserted by LVNs, RNs, and respiratory therapists. CNAs do not insert them. But if you are coding a patient, if your patient goes into cardiac arrest and you're doing CPR, you may be actually bagging a person that has one of these in their mouth. The next one we'll look at is called a nasopharyngeal airway or an NP airway. Now, the NP airway is actually tolerated by someone who is unconscious, or they're tolerated by someone who is semi-conscious. They go in through the nose. It looks kind of like a nasal trumpet, and it goes in through the nose, and it will help support the airway and kind of give us a clean pathway to get air down into the lungs. The other thing that's nice about the NP airways, you can actually the nurse or respiratory therapist can actually suction through them if there's a bunch of secretions at the back of the throat. The next airway we're going to look at is an endotracheal tube or an ET tube. Now, the endotracheal tube is put in through the mouth. They actually can go in through the mouth or through the nose, but they're usually put in through the mouth. The physician or a paramedic puts them in. An RN can put them in if they've gone through extra schooling to become a nurse anesthetist. Oh, sorry, let me back up. So they go in through the mouth, they actually go past the epiglottis, through the vocal cords, and into the lungs directly. And so now you can actually attach your bag mask valve here to the ET tube and push air directly into the lungs. It is a much safer airway. It's a more definitive airway than using any other type of device. But the problem with this is it is kind of hard on the vocal cords. It is kind of hard on these, just on this airway passages. So this type of tube is used when a person's in an arrest situation or an impending arrest, or they're having ventilatory support. They need a ventilator to breathe for them. These can be put in for up to 6 weeks. Sometimes I've seen them stay in for 8 weeks, but usually around 6 weeks is as long as they usually want to leave these in. And then they would actually have to switch them over to a tracheostomy at that point. Now, if you are doing CPR with a person who has an endotracheal tube, remember from your CPR class, when you're doing CPR with an advanced airway, which an endotracheal tube is an advanced airway, CPR, the compressions can become continuous, and the bagger only has to give a breath every 6 to 8 seconds because it's going directly into the lungs, which is unlike when we talked about just respiratory arrest. When their breathing stops, then when we're bagging them, we do one breath every 5 to 6 seconds. With an endotracheal tube. With CPR, it can be one breath every 6 to 8. Now, another type of advanced airway is an LMA or a Laryngeal Mask airway. And these are put in by the physician and or paramedic, and in some areas, some hospitals allow RNs to do this as well, but CNAs would not do this. This airway goes in through the mouth, and the tip of it is going to go into the esophagus, and the air vents are actually in the middle. So then there's this cuff that inflates and surrounds it, and the air comes through this tube, through the middle of this, and it comes out here and goes down into the lungs. We use this type of airway a lot for same-day surgery patients. If you're coming in for a surgery, they'll put it in to support your airway, to breathe for you during the surgery, and they're only in for a couple hours and then they're removed. These are not meant to be long-term. The next type of tube we would see is a tracheostomy tube. Now, as a CNA, you may be taking care of patients with tracheostomy tubes. Some of the nursing homes actually do long-term tracheostomy patients, or if you're working in a hospital, you may be taking care of a patient with a tracheostomy. It's a surgically created opening or a stoma into the trachea. And so then we put a cannula, they put a tracheal cannula, a cannula directly into the trachea, and some of them have cuffs and some do not. And then there's an inner cannula that goes into this, and the inner cannula can actually come out and be cleaned. The patient can be suctioned through this cannula. So this type of device is for long-term management of an airway. So if you are taking care of a patient with a tracheostomy, you're going to see this inner cannula that's snapped on. This inner cannula is snapped onto this outer cannula. You always want to make sure it's intact, that it hasn't partially come out. You will see a dressing that goes around it, and then there are always ties to help hold it in place. It is crucial with a tracheostomy patient that if you notice that this tube is pulled out some, the inner tube has come out, the whole cannula itself has come out, it looks like it's getting pulled to the side, the ties don't look like they're tied on properly, or they look like they're having any type of respiratory distress, you want to make sure you get the nurse or the respiratory therapist immediately. This is helping keep them alive. This is what's breathing for them, or that they're breathing through at this point in time. Now, some of them will be hooked up to supplemental oxygen, and some of them may actually be hooked up to a ventilator, which we'll talk about in a minute. Some safety things to keep in mind with a tracheostomy is you notify the nurse if the outer cannula comes out or if they have any signs of hypoxia. Now, we talked about hypoxia in a previous chapter. Hypoxia means lack of oxygen to the cells. When a person is first having hypoxia, we said anxiety, restlessness, fast heart rate, fast breathing rate, and we might even start noticing them getting a little blue around the lips or the nail beds. That's the beginning of hypoxia, and you need to get them help immediately so it doesn't get worse. If you ignore hypoxia and you don't treat it immediately, that fast heart rate is going to slow down and stop. That fast breathing is going to slow down and stop, and your patient's going to die. So if you notice any signs of hypoxia, we get the nurse or the respiratory therapist immediately. The other thing is keep it covered when you go outside. So if you're taking your patient outside, make sure that there's a mesh cover over it, or they make these plastic covers that go over it. It's kind of like any opening to the body, flies, bugs, things like that are kind of attracted to it. So you want to make sure nothing gets in there. Of course, these people can't go swimming, but we do take them into the showers even though they have a tracheostomy. And so we just need to protect it. We want to make sure, again, they make these little plastic covers that can kind of go over it. So you don't get water or shower spray or anything into it. And when we're shaving, we have to be very careful not to get shave cream in it or to nick these ties in any way. The other thing with the tracheostomy that I cannot stress enough is please always observe your patient. So let's say you have a patient in bed A and a patient in bed B, and bed B puts their call light on. When you're walking by bed A, you just don't walk by them and not look at them. When you have a patient with a tracheostomy, you make sure this looks like it's aligned properly, that it looks like they're breathing okay, that it doesn't look like they're struggling for air, that you don't hear any really rattling or abnormal sounds going on with their breathing, that their color looks good, and that they don't look like they're air hungry or using all their chest muscles to try to draw air in. It's not that you have to stop and go over and talk to them, but just stop, take a look at them. Tube looks like it's in place, color looks good, breathing rate looks okay, they don't look like they're having any distress. Now I can go see what bed B wants, okay? You never walk by a tracheostomy patient without just looking at them. We're going to stop here and we're going to continue part 2 in just a moment.